it's somewhat of a mystery, but to your point, lupus is not only driven by genetics. There are several things, several factors that trigger the loss of tolerance to self.
Science is for everyone, all backgrounds, all ages, all genders, and all walks of life deserve an education.
Folks, it is my absolute honor to bring on Dr. Joy Buie today. Dr. Joy Buie, a nurse scientist and the vice president of research at the Lupus Foundation of America, over 15 years of experience at the intersection of immunology, nursing, and patient advocacy. She earned her PhD in immunology and nursing degree from the Medical University of South Carolina, began her career as the American Heart Association Fellow, studying the role of epigenetics in stroke. Today, her research focuses on making clinical science more inclusive and accessible for communities impacted by lupus, a disease which the immune system attacks the body it's meant to protect. She leads efforts that connects patients directly to clinical research opportunities, creates tools that allows them to access personalized development pathways. Her efforts ensure that real-world patient experiences shape how treatments are developed and delivered. Her work bridges gaps between scientific discovery and people who need it the most. Dr. Joy, welcome on in.
Thank you so much, and thank you for having me.
As we're starting off, I think the first thing I just want to ask is, what exactly is lupus, and how does it affect the patient's body?
Sure. So lupus is an autoimmune disease. So the way I like to describe it is, think about, say, a castle, right? And you are the queen in the castle or the king in the castle. And in order for the king or the queen to survive, there has to be soldiers or an army outside of the castle to make sure that if there's a threat to the castle or a threat to the kingdom, then there is a higher likelihood that the king and queen will survive. But in lupus, what happens is that those soldiers who are employed and deployed to protect the kingdom actually turn on the kingdom, go in and invade, and they begin to try to destroy the king and the queen, right? And so that's what happens in autoimmune disease. Is that instead of the immune system being there to only attack viruses and bacteria that invade or try to invade the kingdom, if you will, the immune system is also trying to attack the king or the queen of that kingdom. And so in lupus, and what makes it different is that it can be systemic, meaning that the entire body can be impacted. And so in systemic lupus, the organs, all of the organs, can be affected by the immune system. So everything from the brain to the heart to the lungs, the kidneys, the skin, joints and muscles, reproductive systems, the eyes, you name it, it can be impacted by lupus. And so that's what makes it so very difficult to treat. The other thing is that it mimics so many different autoimmune diseases. And that's why it takes 4 to 6 years for someone to actually get a diagnosis, and about 3 to 4 physicians before they actually get that diagnosis, because it can present very mysteriously and mimic so many other diseases. So it's very difficult to really nail down or identify the disease, even amongst experts that are considered top of their field.
So as you've painted this picture for us, this sounds like the impossible mission, right? Mm-hmm. Because it is difficult to diagnose, even amongst the experts. It can affect every organ in the body. It's the immune system attacking self tissue versus just the non-self invaders. Where does one even start when it comes to research on this? Like, this seems like honestly, like, where do you even begin? Because there's so many, again, it's not one organ. If it were one organ, then you could be like, okay, let's focus on this.
Mm-hmm.
But where does one even begin on this? Where can you hone in and help people?
Yeah, so that's a really good question. And I think that's one of the reasons why, before the first treatment was developed, it took about 50 years to develop the first treatment for lupus, which was developed in 2011, the medication known as belimumab or Benlysta. And so The thing about belimumab is that it targets B cell activation, right? And so when investigators, really begin to understand the immune system and specifically what's driving the development of autoimmune disease, what they were able to identify is something called anti-nuclear autoantibodies, or ANA. So anytime autoimmune disease is suspected, typically what's looked for first is an ANA. And so if that's present, there is a possibility that one could be vulnerable for developing autoimmune disease. Now that I say that with a few caveats, but the main one is about 20% of the healthy population actually has a positive ANA. But most of the time they're not going to go on and develop an autoimmune disease, right? It could be something that's familial, that's passed down, through the genetic code, but it doesn't necessarily mean that someone is going to develop autoimmune diseases. But that ANA, that positive ANA or anti-nuclear antibody, is produced by the B cell. And so when scientists are really trying to understand autoimmune disease, it's easy to start with the B cell, the thing that's producing those autoantibodies, because it's those autoantibodies that are really drivers of inflammation in lupus specifically. And so the current research looks at, the level at which B cells need to be targeted so that they can, number one, be turned off, or number two, be depleted from the body. And so that's where a lot of research is specifically focused now. But B cells don't act alone. So, in looking at B cell activation, there are a lot of pathways that lead to that. So a lot of the research certainly focuses on the B cell, but then it also looks at what's tangential to that B cell and what's pushing the B cell to become activated, so that those different factors can also be targeted as well.
With B cells and T cell activation, we know that we need these to fight off diseases that could be affecting our bodies, right? Like not self tissue, but non-self tissue, right? For those ANA factors, are they specific to self-attacking? So are you still able to have a functional immune system afterwards? Because I know that's one of the big issues, right? Is how do you target the immune system from not attacking itself, but still attacking things that shouldn't be there?
Wow, that's a really good question. And I think a very important one, right? So right now, what scientists are really focused on is the dosing, right? At what level do you get the best benefit to risk ratio, right? So the question is, do we need to completely wipe out all of the B cells, or, can you stop at 20%, 30%, 40% to allow for some level of protection on both ends, right? So you have just enough immunity to where if your body is presented with a virus or a bacteria or some other pathogen, that you have enough of an immune system to be able to fight back, right? So it doesn't take you out. But then there are other schools of thought, and this is something that I'll get into later, but a lot of the research that we see now is actually looking at how you completely wipe out all of the B cells, and that allows for a reset of sorts of the immune system, where the B cells come back and they're no longer auto B cells. They're no longer producing autoantibodies that are attacking the body. They're actually normal. But that comes with a lot of risk, because if you deplete all the B cells, then to your point, you no longer have anything to help your body fight off the viruses and bacteria.
That also comes with huge implications too, right? Because if I get rid of all the B cells in the body, and then the patient actually starts producing the correct type of B cells, then where does the wrong kind of B cell come from, right? Because then that would argue it's not just genetic, because you still have the same genetic code and you're making the right kind of B cells. Where did the things come from that went wrong, and how can we, prevent that from happening again in that patient?
Yeah, so I think that's a really good question. And I think that's a question that's still being answered, right? It's somewhat of a mystery, but to your point, lupus is not only driven by genetics. There are several factors that trigger the loss of tolerance to self, if you will. And so when we think about risk factors tied to lupus or causes of lupus, we really think about three major factors, but there are others as well. So number one, genetics. Number two is hormones. So that's why women have a higher propensity for developing lupus. And right now we know based on the literature that number is about 9-1. So if you take 10 people living with lupus, 9 of them will be women and 1 will be a man, right? So something about the estrogen hormones, those female hormones that are driving the development of this disease. And then thirdly, we think about things in the environment, right? So when we think about environment, that can be a physical environment, that can be a social environment. We know all of those different factors can really lead to the development of lupus. So we know that there are certainly, toxins in the environment. There's also triggers from viruses, right, that can set off an immune response, and then all of a sudden the body is losing tolerance. There are certain drugs that have been shown to trigger the development of lupus. And then we know psychosocial stressors, things like stress, can also have a major impact on people who have an increased propensity for developing the disease as well. So really all those factors combined over time cause the loss of tolerance in someone who, might have a genetic predisposition for developing the disease. And so we see that because lupus can run in families, right? But it's not always that, monozygotic twins, for example, or twins that, come from the same embryo and then that embryo splits will develop lupus. That's not always the case. So there's something that might be a little bit different in one's environment or what they're exposed to or how they even respond to stress, for example, versus the other.
It's really interesting when you have these twin studies too, right? Like you're saying, it's the same genetics that you've got, and yet one will go and develop lupus and the other won't. That really demonstrates that there was these environmental factors. Now, your doctorate was actually in epigenetics, which are some of these environmental factors, right, that control gene expression. Epigenetics, right, is such a cool topic because it is environment influencing your genome, but it can also be very scary when it comes to something like this, where it's a disease state. Do we know of any epigenetic changes that take place as a function of lupus? Like, is that an avenue of research right now, potential treatments that are like to reset, or is it one where that's still very much a black box?
I have to be honest, the work that I did, so my PhD is actually in immunology, but I did a postdoc in epigenetics, and I was actually looking at epigenetic factors as relates to the vasculature or blood vessels, and certainly ties to sepsis and stroke, right? So different disease areas. In terms of lupus, what we know is that there's certainly lots of different epigenetic factors that can play on the gene. So what these epigenetic factors can do is turn on genes, and they can also turn them off. And the other thing that they can do is cause increased presence of proteins, which are really the functional pieces of the body. That's how the body functions, is through these proteins, right? In terms of specific epigenetic factors that cause lupus to come to bear, I'm not as familiar with that area of research. I know that it's still ongoing, but in terms of what I'm familiar with, I don't want to misinform. So if there are specific questions related to that, I can certainly get those questions and then come back with some answers for you and the audience.
It's just a further complicating factor too, right? That's what it is. Really interesting to me about this, again, like you mentioned, because it's affecting like the primary type of lupus. There's 4 different types, right? And the primary one, where it's systemic, makes it just extremely complicated. And if you're acting on it with epigenetic factors as well as genetic factors, it's just this crazy puzzle again, where it's like, how, again, getting back to when you're finding one root cause, it could be something else being totally affected as well. We mentioned hormones as well that are being acted for the difference in the sex ratios of that 9-1. Do we know of any other genetic predisposing factors that are part of it? I imagine with that ratio, there could be something where if you have slightly elevated estrogen levels just because of a mutation, that could preclude you from, or make it more likely for you to have lupus. Is there something like that in terms of the genetics?
I think, the one thing that is, or at least I'm familiar with, is modifications to the sex chromosomes, right? So when we look at XY versus XX, some males might have an extra X And so that might increase their proclivity for developing lupus. So there's research that's still ongoing in that specific area. There's also a lot of research looking at how estrogen modifies the immune system, right? And modifies responses to, certain pathogens and that are introduced into the body. So that is certainly an ongoing area looking at estrogen and its impacts on the immune system that might lead to increased proclivity for developing lupus. But yeah, there hasn't been any definitive, conclusions made about that area of research.
I imagine that's going to also be a difficult avenue as well, because you're regulating the levels of estrogen and how it might talk to the immune system. But that's not all that estrogen does, right? It also regulates other things in the body. So it's, again, this entire disease, as we're painting it so far, as a giant balancing act of there's all these normal things happening in the body, and they're all just kind of scaled in the wrong direction a little bit too strong. And how do you reset that scale without going too far in the other direction?
Exactly, because that can have negative implications too.
What are some of the other, you mentioned that there was one drug that was developed, the first one in 2011, after 50 years of being worked on. Are there any other types of treatments that are either in progress of being, phase clinical trials that are very promising, or ones that are on the market that are very promising or helpful, and how do they act?
Yeah, that's a really good question. So the first drug that was developed after belimumab or Benlysta was a drug that specifically targets the interferon pathway. And that drug is known as anifrolumab or Saphnelo. And lupus is essentially a disease, like I mentioned before, where, there's so many different factors at play within the immune system, right? And so the goal is really to make the immune system as quiet as possible in order to allow for reduction in inflammation and subsequently organ preservation, right? So interferon, specifically interferon alpha, or type 1 interferons rather, can cause activation of different immune cells in the body, right? And so the idea or the notion with anifrolumab or Saphnelo is that if you stop the activation of pathways that are turned on by interferon, which is produced by different immune cells in the body, then you can essentially stop the inflammation from occurring, right? And so what Saphnelo does is it blocks the receptor that the interferons can bind to on the immune cells, right? And so if interferon can't bind to its receptor, then those pathways in the immune system can no longer be turned on. And so what we see in terms of, its effectiveness, it's certainly been shown to be effective in treating lupus. It's also been shown to be effective at treating skin rash in lupus, right? And it does exceptionally well there. Current clinical trials are focused on using Saphnelo for lupus nephritis or lupus-related kidney disease. And so the jury is still out there on that, but I believe those particular studies are in phase 3. The next drug that was approved for the treatment of lupus nephritis called voclosporin. And so that one is considered a calcineurin inhibitor. And so it essentially has been shown to reduce the progression to end-stage renal disease in people living with lupus nephritis, and is shown to be, protective of the kidneys. The next drug that was developed and it was approved last year for the treatment of lupus nephritis is known as obinutuzumab, or the brand name is Gazyva. So Gazyva is a therapy that was originally developed to treat blood cancers, right? And so what it does is it's an anti-CD20 monoclonal antibody. Anti-CD20 is essentially a flag on B cells, right? And so when other immune cells see CD20 on the B cell, it binds to that B cell and begins to turn it on, essentially. But what these antibodies do is it can bind to the CD20 on the B cell to cause it to become depleted, essentially. So it essentially takes those anti-CD or those CD20 B cells out of circulation. And then there are some other studies that are currently happening, but the major ones are that people hear about often are CAR T cell therapies as well as T cell engagers, right? So I'll talk a little bit about both of those. So I told you about the anti-CD20. Anti-CD20s have the ability to deplete the B cells, but the depletion is limited mainly to the periphery. Now, there have been some studies that show that there might be some depletion at the tissue level, but I believe the results there are inconclusive. With a T cell engager, what happens is that these bispecific molecules, if you will, they have the ability to bind a B cell on one side and a T cell on the other side. So once that T cell is able to meet that B cell, what the T cell does, instead of activating it, it actually goes on to kill the B cell. And right now, the hypothesis is that it has a higher propensity or increased ability to do more depletion than just a monoclonal antibody, something like an anti-CD20, right? And so that's the second dose, if you will, right? That's a higher dose of depletion. And so again, the thought is, binding the T cell and the B cell together so that the B cells are depleted. And those can potentially get at the B cells at the tissue level. And that's important because not only are B cells circulating in the periphery causing inflammation, but those B cells are going into the tissue, right? And so that's where you get all that organ damage. That's where you get the kidney failure and, the brain being impacted, the skin, changes as well as the joint modifications, right? And so the goal here is to not only get rid of the B cells that are circulating in the blood system, but go ahead and knock those out in the tissues as well.
So is it fair to say that these molecules are almost kind of like sponges, where you're particularly sponging out and removing certain molecules from the bloodstream? Mm-hmm. So, for example, when it's the B cell monoclonal, so that means you're only targeting a particular type of B cell. You're just like pulling that out of solution, right? And leaving everything else there. And with the new kind of therapy, you're pulling out the B cell, but you're pulling out other things along with it too that you're targeting and you want out. So it's almost like you're filtering out the blood, right? In a way that's, you're leaving the good stuff and you're taking out the overactive stuff. Is that a fair assessment?
Well, yes. The way I think the difference is the flags that are being targeted, right? So with the anti-CD20, and what I didn't say is that there are different types of B cells, and so the immune system is very sophisticated, and that's why I majored in immunology because I was fascinated by the immune system, but it's very sophisticated in the way that it operates, right? And so they're, just like they're children that mature, right? You go from infancy to childhood and to adolescence. The same thing happens with the B cell, right? And so with those changes across the lifespan, those B cells begin to develop different flags on them or different cell markers.
And so this is within the lifespan of a patient.
Within the lifespan of a B cell.
Oh, okay. So. Oh no!
Yes.
It makes it even more complicated, because right when we were just mentioning that there was just a B cell gone wrong, right? With these autoimmune factors, it was like at least there's a target. But now, if we're saying that the B cells are changing over time, right, as they're being produced, it's not even like within a particular part of your lifespan as a person, but rather when the cells are produced, they undergo maturation, and it's one of those stages that is going wrong.
Yeah, exactly. So with the therapies, right? There's opportunity to develop, different therapies against different flags, right? So depending on where the B cell is in their maturation stage, you might get a subset of the B cells out of the periphery, but you're not going to get all of them, right? And so that's why some inflammation might be able to continue. because you're not pulling out all of the B cells, out of the body, just the ones that are specifically targeted with that monoclonal antibody.
Is that because you don't want to take out all the B cells? Because like we said, it's a balancing act.
That's part of it, yes.
Gotcha. So it's still, that does mean then this treatment, right, is one that's an ongoing treatment where you don't have is it also, my understanding is there's not currently a 1-shot or even a 3-shot to get rid of and cure someone of lupus, right? It just seems like it's a constant battle. And is it that in part because of how you're trying to address each element gone wrong with the B cells, for example, where it's like a particular stage removed, but they're still being made, right? And so you still keep funneling forward the problem.
So that used to be the case about 3 or 4 years ago. But now, so I talked about the T cell engagers, and now we have CAR T cell therapy. And so CAR T cell therapy is the most potent type of therapy for lupus that's currently under investigation. And so with CAR T cell therapy, what happens, and I'll talk about autologous and then allogeneic. So autologous T cell therapy is essentially a process by which a person's T cells are taken out of the body, and then they are genetically engineered to express something called a CAR, right?
So before we touch on the T cells, just for the audience, Dr. Joy, if you can break down the difference of B cells versus T cells, and
Sure.
what would be the benefit of targeting one over the other versus both?
Sure. So that's a really good question. It all depends, and we, the science hasn't gotten to the place of precision medicine, right? Where, one can identify the specific drivers of lupus. No two people have the same types of lupus, right? Some people might have, primarily B cell driven disease, but I think there's a consensus that everybody has a mixture, right? And it's not that, there's benefit to targeting the T cell over the B cell per se, but it's more so thinking of it as, we know that T cells have a role, we know that B cells have a role, but if B cells are the producers of, say, these autoantibodies that are really the culprit for driving all the inflammation, then why wouldn't you want to just get rid of the B cells, right? And then leave maybe everything else intact so that, perhaps the innate immune system. So there are two arms of the immune system, right? There's the adaptive side, and then there's the innate side, the immune system that you're born with, right? And so if we're specifically targeting the adaptive and we're leaving the innate or the immune system you're born with, some of those components alone, then perhaps you have a little bit of immunity left so that you're not completely all the way vulnerable and susceptible to developing other diseases or infections and things like that.
So for those at home, the adaptive versus innate, right? We're talking about immune memory with the adaptive immune system, where it's, reinfections and vaccines will be acting through that pathway versus macrophages on the innate immune system, where it's, the macrophage cells that are eating up the potential bacterium, but you're not necessarily going to have a true immune memory from it.
That's right.
Right.
That's correct. That's
you're leaving a little bit of a root system for the patient to. This is like your frontline kind of defense. You don't, and you were kind of modifying the backup defense, essentially.
That's correct. So essentially, when we're thinking about, again, the dosing, right? And we're thinking about targeting a B cell versus a T cell. With B cell depleting therapies, they are specifically reserved for people, at least right now, and specifically when we're talking about CAR T cell therapy, they're specifically reserved for people who have something we refer to as refractory disease. So refractory lupus is lupus that does not respond to current standard of care. And so a person has to have shown that they are not responsive to current treatments that have, repeatedly been shown to be effective in treating lupus, right? and causing people to go into remission, what we call remission, right? And so if those therapies aren't working, then looking at things like the anti-CD20s, the B-cell depleting therapies, the T-cell engagers, as well as the CAR T-cell therapies, those are the treatments that are being considered now for people who haven't responded to the traditional medicines that have historically been used to treat lupus. And so from a physician's perspective, and I'm not a physician, but that's how they think about the treatment of lupus, right? Is if we can get away with doing something milder that's not going to open you up to all these infections, then that's what we're going to do. But if you don't respond to, these milder treatments, right, that don't cause as many side effects, then, we have to pull out the big guns, if you will, and just kill the immune system off as much as we can. And so that's the difference in, I guess the approach to treating the disease. And so that's why I said we haven't gotten to a place where there's personalized medicine, where we can, look at under a microscope or a blood test and say, okay, this person needs to start off with all these B-cell depleting therapies because they're not going to respond to the other stuff. We're not there yet. But what we do know is that, if a person doesn't respond to current standard of care, then these other therapies are currently being developed to treat the more severe types of disease.
It unfortunately doesn't surprise me, I guess, that it's not yet personalized because, like you said, there's not even a test to tell you if you have lupus that I could just go in and get from the doctor's office today. Like you said, it was like 4 to 6 years for a diagnosis, right? And so if that's already a big barrier, then the personalized element to it is going to be a little bit longer, I would imagine, before it's going to be used.
Right. Absolutely. So CAR T-cell therapy, as well as some of these other therapies, they are being used right now in oncology, right, to treat certain cancers. But the more and more we advance in technology, the more and more, we're able to develop blood tests. I think the closer we get to personalized therapy. The challenge with that, though, is that lupus doesn't stay the same, right? And so a person can start off with just mild skin manifestations, right? And then, a few years later, they can have joint involvement and then eventually go on to develop kidney involvement, right? And so, with personalized treatment, that might come with some caveats. And one of the things we think about at the foundation is how do we make sure people are getting what they need, right? Without, creating these limitations, right? Because there is one thing to have a drug approved by the FDA, but it's another thing to make sure that from a payer's, perspective, the drug is going to be covered, right? And so we don't want people to be boxed in, if you will, to be labeled as, oh, well, you have this type of lupus, so you need these specific treatments, because the lupus can easily shift to become something else over time. So we have to make sure that we protect the patient by being clear about the fact that this disease can change. It oftentimes will change over time to become something completely different than it was, at the very, very beginning of the patient's journey.
So can there be a scenario where the patient goes into remission from treating one, I guess, almost flavor of lupus to where then it starts attacking a different part of the body, and now you have to have a different approach and a different regime to help that same patient that you thought that you've cured beforehand?
Absolutely. Wow. Absolutely. Yeah. And oftentimes, with remission, it's not always a drug-free remission, right? So oftentimes it's remission that's induced by therapies, and the person has to stay on those therapies. And what we've heard from patients is that sometimes those therapies just stop working for some reason or another, right? Something has shifted with the immune system. It's figured out a way to evade, those therapies, or it's changed, something else has switched on. And so it can become, something completely different. Or oftentimes what we see is that people will develop another autoimmune disease, right? So once, that positive ANA is there and the immune system has lost tolerance, then there's certainly opportunity for multiple autoimmune diseases to co-occur in one individual.
Are because the ANA is right that we talked about with the B cells are markers of autoimmunity and not necessarily just lupus, is there any possibility for cross use of these drugs? Like when you develop a drug for one autoimmune disorder, like let's say lupus or something else, is there a possibility of there being crosstalk? So like investing in one could lead to treatments in multiple? Like how much, I
Yeah.
guess, off-label use can you have in helping other patients from what, because you even mentioned like CAR T cell primarily used in cancers, now can be used in this instance. How much crosstalk is there between different disease states that you could then
Yeah.
use and like apply those drugs? So almost double dipping in terms of the drug development side of things.
Yeah, that's a really good question. So one thing that we're beginning to see is basket trials where patients with different autoimmune diseases are being put in the same group and studied, with one therapy, right? And this is certainly, something that's happening right now with T cell engager research studies as well as CAR T cell therapy research studies. And so things like scleroderma, Sjogren's syndrome, myositis, those types of diseases that are autoimmune diseases, they are being evaluated side by side with lupus. Yeah.
So given how many avenues that things can go wrong in, how many organs can be affected, how there's changes over time, research for this must be a pretty big investment. Can you talk to
Mm-hmm.
us about a little what type of when someone's doing research on this, what kind of research, what does lupus research look like? And just some of the cost and time associated with this, like the manpower that would go in, because again, at every avenue we're talking about, here's something else that can go wrong or can go wrong in a different way.
Yeah.
Again, this seems like something that, again, a lot of grants, a lot of private funding needs to be going towards to help support. So just an idea for folks as to why it's important to fundraise and just like how much something like this could cost or does cost.
Yeah. So when we're talking about drug development, right? Oftentimes it starts in an academic medical center. So, people like me who are trained as a basic scientist will start at the bench. And I can share just a little bit about my personal journey. So my mentor in graduate school was actually a physician who had some experience working at the bench. But, one of the things that he did, which I found was really unique, was that he worked in the clinical setting, would identify problems, right, in the clinic, and then bring it back to the laboratory and say, hey, we need to think about how we can address X, Y, or Z, right? And so that's basically how a lot of research is generated. It's looking at a problem and saying, okay, we need to find a solution to this. So working at the bench, depending on how well funded the laboratory is, how many resources are available, the research can take anywhere from 5 to 10 years to get to a place where an investigator can put in something called an IND, and so to the FDA. So an IND is essentially a new drug application that essentially asks the FDA, can we evaluate the therapeutic efficacy of this particular treatment in humans, right? So in the preclinical space, we're working with cells, we're working on the molecular level, looking at different pathways within those cells. And then oftentimes the research will transition to some type of animal model, whether it's a Drosophila fruit fly or a mouse. Sometimes, it can be larger mammals, but that just depends. And that alone costs tens of millions of dollars over time, right? And then transitioning that to, the clinical laboratory space where, first you have to check safety in humans to make sure that this new drug isn't killing people off. Again, millions and millions of dollars, right? To, set those studies up, find clinical trial sites, pay the investigators, compensate the patients for their time, and then make sure that, if there's anything that needs to be managed in terms of making sure any hospital bills are covered, making sure that You can provide transportation, housing if necessary, all those different things to the patient. It's very, very expensive, right? So if the drug is deemed safe, then it moves into phase 2. Phase 2 is a phase where more people are recruited to that particular trial. And in addition to evaluating safety, things like efficacy are evaluated to see, if there's some predetermined outcome measure, and we'll take lupus nephritis, for example. Can we reduce the amount of protein that's spilled in the urine? Because oftentimes what happens in lupus nephritis is that the kidney essentially gets these holes in it, right? So the kidney is specifically responsible for filtering the blood, right? And, making sure that all the bad stuff gets out, right? But you're not supposed to lose your protein because protein has very specific functions in the blood, right? But in a damaged kidney, that protein can get through, right? And so the goal, for example, with those trials is to make sure that protein is essentially not found in the urine. So that's one of the markers of looking at that.
And so phase 1, because you're not looking at efficacy or how well the drug is working, phase 1 for safety is healthy patients, right? Like someone who is not high risk, you give them a high dose of the drug, make sure that they're okay, and then you move on to a susceptible population, for example, or is it in like how are you selecting the patients, right, to test in 1 and 2 and then 3?
Yeah, so it doesn't happen that way in lupus where you have a healthy versus a sick patient. Everyone has lupus nephritis if we're studying that, right? Now, in some other areas, some other disease areas, that might be the case. But most of the time, lupus trials, it's a randomized control trial where you have to have someone who has that specific disease as the comparison group.
Is that because you're modifying the immune response? And so if you're modifying, in a healthy non-lupus patient, that could yield a bunch of downstream stuff for said patient that are unrelated. Dr. Joy, this keeps getting more and more complicated. And like it's a miracle that y'all are able to make any kind of push. And the amount that you are already helping people, right? Because it's like at every single turn, this is giving us something even more complicated that was not necessarily originally expected, right? And it's even on the drug trial study, like, oh yeah, the normal phase 1 clinical trials we can't do.
Yeah. So in lupus, typically there's a comparator group, right? But it's interesting that you say that because with the CAR T cell therapies that I talked about, there is no control. If you're in the trial, everybody gets the drug.
So what do you compare against? Like how is it within this patient? Like what does one consider like positive standard versus standard of care in that kind of it? Is it one of those where it's like just nothing's working, so we just got to go for it?
Yeah, and then looking at the outcome measures, right? So the outcome measures are oftentimes predetermined, and so the first, like I said, there's the safety, right, and looking at whether or not the drug is safe. Then we move into looking at efficacy and effectiveness for sure. Yeah, but there's predetermined outcome measures, so you're measuring against those predetermined outcome measures. Yep.
And then when you get to phase 3, so you've looked at efficacy in phase 2 or how well the drug is working for particular types of measurements. With phase 3, is it just looking at different measurements, like expanding that and or the patient number?
Yep, expanding the measurements and then also expanding the patient number. And that's where we get into looking at things like efficacy and effectiveness along with safety. Yeah.
And so at any one of these stages, right, that we've talked about, tens of $1 million going in, you
Billions
could stop.
Sometimes.
Billions with a B. Yeah. It could end, right?
Yes.
So there's never even if you get to phase 1, there's not a guarantee, even if it looks like in the cell line in the dish or the fruit fly that you're working with, that it's the best drug ever, it could end at phase 1 if it's not safe in the patient, right?
That's correct. That's correct. That's absolutely right. And a lot of trials do fail. They absolutely do. And, one of the major reasons that trials fail is due to the inability to recruit enough patients. So what we're seeing right now in the U.S., and the last time I checked, there were 148 clinical research studies. So when we think about clinical research studies, there are two big buckets. One is observational and the other is interventional, right? And so certainly, there are interventions beyond, just medications, interventions like peer-to-peer education, interventions like self-management, interventions like behavioral modifications, exercise, sleep modifications, et cetera, right? But when we think about the number of interventional trials that we've seen, I think there's been exponential growth in the lupus space over the past decade or so. So this is a time like no other where a lot of investments are being made in lupus. And so that has put a lot of pressure as well as friction points on the system. And right now, what's happening is that pharmaceutical companies aren't able to find enough patients for these trials because number one, there's so many, but then number two, for a lot of these trials, as I mentioned before, because they're certainly risky, the inclusion-exclusion criteria are just very stringent, right? And so I talked about that those unicorn patients that have refractory disease, they've tried and the medications failed them. I don't like to say they failed the medications, right? But the medicines just didn't work. And so it's finding those people who are sick, but not too sick to enter into these trials that has become the real challenge. Yeah, for sure.
And the numbers game too, right? Not just because if you don't have enough, you can't really progress or can't have the statistics behind it. But I'm sure if you have, 10 patients and 3 are having this side effect that you're like, well, we might need to shut it down. But if you have 100 and 3 are having the side effect, then you might want to progress too, right? So it's on both ends.
It's on both ends. That's exactly right. And the other challenge is the expertise on the physician side, right? And so because there's so many trials and the physicians who are the experts at running trials are also the experts at treating patients. And so they have limitations on their time as well. And so, it's finding the sites, it's finding the doctors who can run the trials, but it's also finding the patients. And oftentimes what we know is that people who are sicker tend to not be, in residential areas that are close to an academic medical center. And that's because if they're going to an academic medical center where, it's the top tier treatment, right, top tier physicians, then they have a higher likelihood of doing well with their lupus because they're being treated by the experts. And so oftentimes the patients who really need to be engaging in the clinical trials don't, get identified because they're not in the right locations. And so that's something that we're working on at our organization, is trying to figure out where these patients are who don't have access to high quality care so that we can begin to educate them about opportunities to participate in clinical trials.
And the unfortunate truth is, like you said, 4 to 6 years usually for diagnostics. And if you're in a rural area, I'm sure that identification of a candidate patient that could have lupus is going to be very difficult to do.
Yes, absolutely, 100%. And it's, it's an ongoing challenge and one that we think about every day is, how do we touch these people? Because not only are they not able to get enrolled in the trials, but like you said, lots of delays in diagnosis. And then once they actually get a diagnosis, is there too much damage to the point where it can't be reversed, right? How much preservation is actually possible if you live with this disease for so long and you haven't had any type of treatment. So, those are the things that we're trying to figure out at our organization. And, the question is always, how do we close the gap in care?
Yeah, it's such a gigantic puzzle that y'all are solving, and it's incredible the work that can be done and is actually being done on this front, right? When the patient is diagnosed with lupus, right, and these autoimmune elements are taking place, and we're trying to regulate the immune system, how does one identify where the patient is having a lupus-specific symptom or something secondary? Because that seems further complicating in terms of, like you said, there's multiple presentations of lupus. There's the 4 types. There's the different stages within each type as well. And then there could be other things that are also being affected. So how does one parse out what is lupus, what is not lupus, to best provide the best kind of care for the patient?
Yeah, that's a really good question. And so there's been a lot of work that's been done on looking at, and answering the question about what is lupus, right? And how does it show up? And so there have been several iterations of something we call classification criteria. And classification criteria is used oftentimes by clinicians and physicians for various reasons, but it was specifically developed for clinical trials and identifying people with what's considered textbook systemic lupus erythematosus, or SLE. And so there are a number of factors within those criteria that specifically point to classical lupus, right? Classical lupus symptom. Outside of that, there are certainly unique manifestations of different diseases that live outside of lupus that can certainly be identified by an expert, right? And then in addition to those things, looking at the blood, right? And so someone who has, antibodies that are specific for, say, rheumatoid arthritis are going to be very distinct from antibodies that we look at that are specific to lupus. I would imagine the same is true for diseases like scleroderma, where that there are specific things that are happening in terms of fibrosis that are typically absent in people with lupus, right? And so there are distinct things that change in these autoimmune diseases, and there are certainly distinct tissues that are impacted, and certainly looking at how they change, right? So maybe a biopsy is necessary. And when we think about biopsies, certainly liquid biopsies, tissue biopsies, things of that nature can really give us clues in terms of whether something is lupus or not.
So, Dr. Joy, I know we had scheduled you for an hour. Can we keep you for a couple of more minutes? Would that be okay?
Absolutely.
Awesome. Thank you. I'm having a blast chatting with you, and there's so much that we're learning, particularly about how little we actually know. It is the big thing that this comes to. So I wanted to kind of focus on a positive ending element, right? Which is that you're head of vice president of research, right, at the Lupus Foundation of America. Could you tell us a little bit about what that entails, and what, in terms of the research direction that is being gone in, that excites you in terms of what are we looking forward to? What is like a big goal? And just from your day to day, that little element of hope, because I feel like it can be very much be a disease where, even as we're describing it feels like there could almost be no hope, right? Of everything's changing. There's all these factors. It can be genetics or it cannot be. All my organs, all this kind of drug, the amount of money that goes into the payment to getting these drugs, it could be really lonely and isolating. And so just I feel like that research message of hope would be a great kind of spin to end on.
Yeah, absolutely. And thank you so much again for the invitation. There's so much that's happening right now. This is the best time for lupus, I think, in the history of even having identified the disease, right? And so one of the things I will say is folks are now having conversations about cure. And that's something that has never happened in the past. So I talked about CAR T-cell therapy. I talked about, right now there's certain parameters around it in terms of who has access to it, those with refractory disease. But the original studies were done by an investigator known as George Schett. And Dr. Schett is, he lives in Germany. And so his research was initially done in Germany. And he studied, I believe, 7 patients with lupus, and it may have been more, don't quote me on that. But he put out a paper, I believe, last year. It was a follow-up paper just showing how those different patients have been doing over the past 2 to 3 years. And I believe all of them had maintained their remission. So they were in remission without additional treatment. They were young when they were treated, so maybe late teens, early 20s. And a lot of them were able to go on and live their life like they would have done without having, ever having a diagnosis, right? So those are the conversations that are happening right now. And certainly we don't believe that CAR T-cell therapy is going to be the treatment for everyone because, of course, as I mentioned before, it comes with high risk. But, to have a treatment that can certainly reset the immune system is quite fascinating, right? And so for those with very debilitating, severe disease, that impacts them so much to the point to where they can't get out of bed in the morning, they can't go to work, they can't take care of their children, they can't engage with their family as they would have before. There is hope on the horizon, right? And certainly that might be a potential opportunity for them.
And then, Dr. Joy, when you say remission and cure, what does that look like? So, because again, right, that could be different for different folks. Do you mean by that as I have a functional immune system now that attacks what it's supposed to and not me? Like we're talking like a full on, this is...
That's 100% correct.
Wow. Okay. So it's not even just like you have a tampered immune response in some level. It's like you are totally set and you are good to go.
That's correct.
Wow.
That's correct.
That is amazing.
Yeah. But that, again, I say that with caveats, right? Because that's not going to be a treatment, at least for, the next 5 years, that's available for everyone with lupus. Because there are certain side effects that come with that can be just as dangerous. And so that therapy is specifically, set aside for people who would essentially have more benefit, than potential risk, right? But there are, T-cell engagers that are believed to be less potent in terms of, those side effects. But again, we don't know yet. The jury is still out. So those things are still being studied. In addition to that, though, there were guidelines, new treatment guidelines that came out last year from the American College of Rheumatology, and previously before that from the European League of Rheumatism, Arthritis and Rheumatism, or EULAR. And that's the European, I guess, college board for rheumatologists. And so essentially, those guidelines gave physicians a lot more clarity on tools that can be utilized for the treatment of lupus. And so what we're doing at the foundation is creating a tool for patients to understand how lupus is supposed to be treated according to the guidelines. One of the things that we know from the extant literature, the scientific literature, is that people living with lupus, really a lot of different diseases, don't adhere to their treatment regimens for one reason or another. A big reason, though, is anxiety around side effects. So people don't want to take their medications because of the side effects. And so what we're working to do at the Lupus Foundation of America is demystify the clinical care and treatment process so that people feel more confident taking their medications, right? And then understanding if you experience these side effects, what do you do about it, right? When to call the doctor, when to follow up and have those conversations. What do you need to say? What are the questions you need to ask so that you can work with your physician to achieve the goals, whether it be having a baby, which is now, more and more possible for women living with lupus, whether it's going back to work, whether it's getting another degree, whatever it is, we're equipping people living with lupus with tools to be able to have those conversations, to be able to better understand the disease and how to manage it so they can work as partners with their physician, as opposed to, taking on the persona of I'm the patient, you're the doctor, right? We're in partnership and we have to work together so that we can achieve our collective goal, which is making sure that the patient has the highest quality of life possible, right? And so that's very important because what we know is that even with all these medications, sometimes people don't take them, right? And so they're tools, but if you don't use them, then you're not going to realize those outcomes that are potentially there. So,
and a big part of that too, I imagine, is that certain populations as well have had historically horrifying, right, effects with medical care, where it's just like you've been given a drug and it's done something terrible to one's body, like in the 30s and 40s and 50s, right? And so there is this immense distrust from a historical perspective that you also have to overcome.
Absolutely.
And like, what would you say is the most difficult part of that education forefront? Because it seems like it's one of those where you want to go from just saying, take this pill, to being a dialogue. And that could be a very, very difficult door to open up. What is the biggest challenge there? And I guess, what has the success look like in your eyes? Has the difference really been going forward, and have you all been making a difference and moving forward in that field?
Yeah, that's a really good question. So we're in the process now of digitizing the tool. We haven't rolled it out yet, right? But in our research and really understanding the dynamics, I think trust is earned, it's not given. And in order for someone to be deemed trustworthy, they have to show that they are, right? And I think that that's the bottom line. Because we used to talk a lot about concordance and things of that nature, right? Like having racial concordance or sex concordance or whatever. But that, given the current landscape and who the practicing rheumatologists are versus who's living with the disease, that's not going to be possible. That's not a realistic goal. So the question is, yes, we're educating patients, but how do we educate physicians so that they, understand the language and where the conversation needs to start? And, what we've realized is, regardless if you have a label of lupus or not, all human beings want people to value what they value, right? And so our specific activity or our specific tool really starts with a values assessment and helping people understand what they value so that they can clearly articulate and communicate that to their physician, right? But on the flip side of that, we're thinking about how do we educate providers so they can stop for a minute. They have, most of them, it's not even them who's setting their schedule. They're run by the bean counters, right? The administrators who are saying, we got to bring this much money into the hospital. You need to see this number of patients in 8 hours in order to make sure that we meet the bottom line, right? And so it's always this tug of war, right? But we need to educate physicians about, okay, this person is coming in with these different walls, these different experiences, understand the context of which they come from, and start with what matters and what matters most to you. Because if you don't understand that, then there is no conversation that happens, right? The physician and the patient have to figure out, where do we converge? Where do our values merge, right? And letting that be the starting point to the conversation, right? Then we can build upon that because we have this one singular shared goal, and then we can go from there. And I think that's how you get there. That's even with, you and me, right? What is our singular shared goal, right? And then we work together to get there. I mean, that's with any relationship. And I think that's how, medicine has to be modified in order to make sure that those patients who are hard to reach, who do come in with, the trust issues and who have had terrible experiences with the medical centers, or even have family members who are saying, don't go, don't take that, try this natural herb over here, all these things. And I'm not saying that that's necessarily wrong, but it's how do you use what traditionally has worked and the things that, are more conventional to get to where you want to go. And so that's what physicians have to contend with. And we're working to really figure out how we convey that message to them as well.
And it really doesn't feel like you're asking for too much on that front, right? Like that almost seems like a base almost requirement, right? Like I'm going to speak to you with respect and explain to you as a human being what this thing does and just account for how you feel. Like right? That doesn't seem like a crazy thing. It doesn't seem like that there should be a crazy goal to try to hit.
No.
And it's a shame that y'all do have to put so much time and effort into this. But if anyone's going to be doing it, I want y'all to be doing it. That's, again, why we partnered with the Lupus Foundation of America, is because y'all do incredible work advocating for the research and for the patients and helping patients. Like, we have friends in this community who you have, as the Lupus Foundation of America, have directly helped. And I can't, I hear that, I'm like, well, this is an easy charity, an easy group to get behind when you see, our friends are being helped. So you mentioned, there is this plan going forth and advocating for the patient and allowing that communication to go easier and to be more, I guess, meaningful in terms of the original outcomes, right?
Mm-hmm.
There's also these a drug that with the CAR T cell therapy that is a potential cure as well for at least some groups of patients. When we're looking forward on this and just in the next 10 years, what do you see, Dr. Joy, as what we have to look forward to in terms of research? Because the research has kind of, from 2000 to now, there's like a very long period of slow, and it feels like now we're almost in a renaissance period of this type of research. What are we
Mhm.
got look forward to, and what do you tell folks who are, thinking about donating where their money's going to go to and how it's going to make a big impact going forward?
Yeah, I would say because these therapies are, available, I think there's going to be an opportunity for people to live longer, to live better, and to live with higher quality. So much so that opportunities, for example, for pregnancy will become more prominent, will become more prevalent. Opportunities to go back to work will certainly be there. And so, what I foresee is, thinking about how we fill in the gaps that still exist, right? We still have huge disparities in childhood lupus, where a lot of, people who develop lupus in childhood and are living, with this disease in the pediatric world don't have, access to the treatments that they need, right? The research has, for the most part, been focused on adults with lupus. And so a lot of the research funding still needs to be funneled into the pediatric population. Also, the other issue that is still, very problematic is fatigue, chronic pain, as well as brain fog, right? And so those are areas that still haven't been addressed, even with the current therapies. And so thinking about research investments there is very, very important. I talked about pregnancy, and earlier on, I talked about the role of genetics, right? And so when we think about moms who are living with lupus and then they go on to have children, what's top of mind, I would say for most of them is how do I manage the risk of passing this down to my child? And is there a way to prevent it? And so what we started 2 years ago is a research portfolio where we are investing in ways to understand who is at increased risk for developing lupus so that we can eventually, support trials that are specifically designed to prevent the development of the disease or slow its progression. So I think, in addition to those, we talked about personalized and precision medicine. To me, I think, those areas, those are key areas that are, certainly being focused on for the next 10 years or so. So prevention, precision, personalized medicine, and then closing the gaps in childhood is research as well. And then thinking about those symptoms that are, haven't historically been addressed with current therapies, fatigue, pain, and again, brain fog, which a lot of people living with lupus report having. So, yeah.
I think one thing you just mentioned there that kind of surprised folks is about the pediatric side of things, right? Because
Mhm.
we were talking about at the beginning of how, estrogen levels and elevated estrogen levels are elements of being, measuring in terms of lupus, right? And you don't think of that in someone who's pre-puberty, but it sounds like that even kids can have lupus-like symptoms. What
Yeah.
what does it look like when a kid has lupus? And just from your description, it sounds like we really don't have any idea what to do. Is that a fair
Yeah.
assessment?
So most of the time, children are developing lupus right around the time where hormones are changing, right? And so when those estrogen levels are rising, that's when we begin to see the diagnosis occur. So it's rare that you'll get like an 8 or 9 year old with lupus. It can happen, but most of the time, they're into adolescence at that point where those estrogen levels are beginning to rise. They're experiencing monarchy and things of that nature, or their period, and so that's when we see the lupus develop. Yeah.
Gotcha.
So
So,
it's an estrogen
mhm.
piece to it. And there's some schools of thought, I don't know if this has been proven or not, but certainly there's some schools of thought that genetic predisposition is a lot stronger there.
And I wonder too if that could be something that's tested down the line. Like you mentioned, folks having kids, if you could do
Mhm.
embryo screenings on it as well. Like just, if you're doing IVF and we already have this big list of things that we pre-screen for those particular patients who are thinking about being moms, that could be maybe something too to help alleviate that stress is we can test the embryos maybe at some point, right? Even though it's not the only factor.
Yeah, that's what I was gonna say. Lupus is hard because it's not monogenic, meaning there's not one gene that causes it. It's very polygenic in nature. So there's a lot of different genes that have to be turned on or off in order for those genetics to lead to lupus, essentially. So I think that that's a very difficult one, and especially because of the hormonal factors as well as the environmental factors that contribute. Maybe in the future one gene will be found, but right now the science doesn't show that at all.
Yeah,
Yeah,
I guess that's how
unfortunately.
you were saying, right? Like there maybe are some things that you're passing on genetic elements, but because there's issues in terms of epigenetics where
Mhm.
environmental
Yep.
factors are tuning the gene, so it's not even a mutation, it's just
Right.
I'm opening up this part of the DNA or I'm closing it up to elevate
Yeah.
it or lower it, and that leads to disease state. You can't screen for that because the
Right.
DNA of mom and kid would be the same. It's just one is activated and one isn't, and so that's what would make it hard to screen for.
That's right. The other thing, and I didn't talk about like the environmental factors, but we know that lack of sleep is a huge contributor to the development of lupus. Things like obesity, smoking, all those factors certainly contribute to the development of lupus. And then what research is showing now is that adverse childhood experiences, as well as things like domestic violence, have also been shown to contribute to the development of disease because of the stress, right? The psychosocial stress that it causes. So there are a lot of extraneous factors in terms of lifestyle as well as social factors that have been linked to the development of the disease. So there is just, it's really a hard disease to understand. But I think that's why research is so important, right? Because we have to understand how it works in order to prevent it. And so a lot of the folks that we work with are certainly doing the work to help us better understand those lifestyle diseases, those social factors, also genetic factors that lead to the development of lupus.
So, in
Yep.
hearing about this giant puzzle today, right, I think more and more as we're talking about it is just, I think you're taking the puzzle, Dr. Joy, and every couple of minutes we keep shrinking the size of the pieces.
Yes.
Um, how can folks at home who are listening to this conversation, whether it be live or later on listening to the recording, folks that want to make a difference and help in terms of the research and for these patients, what's the easiest thing that someone at home can do to help?
Yeah. So for those people who are living with lupus, we have a registry at the foundation called RAY, which stands for Research Accelerated by You. We utilize that registry in a lot of ways. For those people who are interested in participating in clinical trials, we share information about opportunities to participate in clinical trials that might be right for you based on the information you share with us. In addition to that, we take information within the registry and we work to make sure that patient preferences and your voice is heard, amongst people who work in the pharmaceutical industry. So oftentimes what we're doing is we'll look in the registry and we'll, look at folks' responses. And if the pharmaceutical company comes to us and they say, hey, we want to talk to 10 patients who have these different factors, then we'll recruit you to go and sit in a focus group or, be a key informant as it relates to lupus, right? Because we believe at the foundation that patients are the expert. And your voice is the single most important voice in this space, right? And so we want to make sure that patients are driving the research and not the scientists. And so we do a very intentional job of making sure that that happens. In addition to that, for people who, are certainly family members of people with lupus, specifically first degree relatives, we do have a study that's going that's focused on the prediction and prevention of lupus. And so you can certainly reach out to me at buie@lupus.org if you want more information about that particular study. And then, we have a lot of different walks that might be in your area. So if you're interested in attending a walk, fundraising for a walk, then we certainly have that information on our website. We have a lot of different ways that you can give monetarily as well to get involved with the work that we do at the foundation on the research front, on the advocacy front, which is also important in making sure people have adequate access to care. And then we do a lot of work around support groups as well and education, making sure that people feel supported through their journey.
It's amazing. Thank you so much, Dr. Joy. And thank you again for your time today, for sharing your knowledge, your expertise, and answering all of our questions. Is there anything that we have not yet touched on today that you wanted to talk about? Or if we've hit everything, is there a closing message that you'd like to leave with the community?
The only message I'll say, and this specifically to people living with lupus, don't give up. There is hope on the horizon. You have partners at the Lupus Foundation of America that are working every day on your behalf to make sure that you have a battle buddy that's battling this disease alongside you, to make sure that you can live the life you want to live without barriers, without any hesitancy, without any reservation that, something bad will happen. And so we're working every day to provide resources, information, support, and certainly doing the research and talking to everyone on Capitol Hill to make sure that you have a clear and healthy path forward. So thank you for your time, and thank you again for the invitation. I'd love to do this again if the opportunity presents itself, and I hope the things I've said today have helped everyone listening to this conversation understand lupus a little bit more.
Dr. Joy, thank you. And you have an open invitation to whenever you want to come on and talk to us. That was absolutely amazing. And again, thank you for your time, expertise, and I thought that was just a beautiful end as well. We really, really appreciate you. Thank you again so much, and have a wonderful rest of your Sunday.
Backgrounds, all ages, all genders, and all walks of life deserve an education. Come be one of us.